Hi, I'm Nicole West. Thank you for coming to my presentation on why we should expand our cellular therapy program to include CAR T-cell therapy here in Montana. CAR T-cell therapy, it stands for chimeric antigen receptor T-cell therapy, is also known as immune effector cell therapy, or IEC. There are currently 2 FDA-approved indications for CAR T-cell therapy. For acute lymphoblastic leukemia or diffuse large B-cell lymphoma, with 2 FDA-approved products, one being Chimera, which is used mainly in pediatrics, and Yescarta, which is used in adult patients, which is what Billings Clinic Cancer Center treats. Billings Clinic is the largest healthcare organization in Montana. We have a 304-bed level 2 trauma center with over 50 specialties. We are a physician-led nonprofit organization that is affiliated with Mayo Clinic, and we have had magnet designation since 2006, and we're the first facility to have that in Montana. Our only competitor is St. Vincent's Healthcare. Their campus and ours sits right against each other, with 11th Ave North being our only separation. We are a regional healthcare center, in a rural at that, but we treat patients in the Montana, Wyoming, and North Dakota region with 13 regional partnerships. The slogan of Billings Clinic is "We care where you are." The idea being that we go to we take our care to these sites to treat patients close to home. The mission of Billings Clinic Cancer Center is to provide leading-edge cancer care for the patients and their families, and to be envisioned to be nationally recognized for premier cancer care and the first choice for patients and their families and referring providers. As I said, we are rural. 35 to 40% of our patients still travel over 100 miles, even with us going to those outreach sites. We do have currently 6 accreditations, including one for the cellular transplant program, which is under the Foundation for the Accreditation of Cellular Therapies, known as FACT. We have been FACT accredited since 2016 and have seen an increase in the growth of our program since that time. The cellular program started in 1997 as a joint venture between us and St. Vincent's. However, in 2002, St. Vincent's no longer wanted to be involved in the cellular therapy program. And so Billings Clinic has been the only cellular therapy program in the region since that time. We saw 131 hematologic patients in 2019, which came to about 8% of our total cancer patients. We are not currently immune effector cell accredited as a part of our program. We are accredited for stem cell. We did have our reaccreditation inspection last November and did have them inspect us at the same time for the immune effector cell program. In the last 6 months, I do know we've had to send at least 2 patients out to other sites to receive this treatment because we cannot offer it. The FACT does have 2 immune effector cell programs roughly in our region, the one being in Sioux Falls, South Dakota, which is about 10 hours away, and the other in Aurora, Colorado, which is about 8 hours away. In 2019, we did participate in a phase 1 immune effector cell clinical trial treating multiple myeloma patients with CAR T-cell therapy. That study did allow us to put the infrastructure in place at the cost of mainly the trial, or the any cost Billings Clinic paid were in people's roles that were already being paid. The infrastructure, the supplies, equipment were all paid by the trial. Billings Clinic does practice a professional practice model. We value that we're multidisciplinary. We want shared governance where everybody has a voice in how patients are cared for. This does provide for improved patient outcomes and improves staff engagement and satisfaction, as well as retention, which is why it's used at many magnet facilities. Our external environment assessment, we are the largest county, and in the largest county, Yellowstone, and the largest city, Billings, in Montana. We are, as I said, rural healthcare provided over three state region. Our main competitor has no interest in cellular therapy. There are currently 95 FACT accredited immune effector cell centers in the U.S. There are none in our region, and this is fast growing. Last year, it was only 75 to 80 centers were immune effector cell accredited. There are 2 FDA-approved indications for immune effector cell therapy. However, last year there were 180 clinical trials taking place to investigate the use of these therapies in other hematologic and solid cancers. As far as demographic information, Billings has about 160 residents of the total almost 1.1 million residents of Montana. The population, though, of the state is about 6.8 people per square mile. Majority of our residents are white at about 89%, and Native Americans make up about 7% of our population. 20% of our residents are over the age of 65. This is relevant because, as everyone knows, cancer becomes more prevalent the older you get. Median income for Montana residents is about $52,000, with about 90% of the residents being covered by insurance. Wyoming has a smaller population, about half that of Montana, and with about 5.8 residents per square mile. Most of their residents are also white at 92%, with about 10% being Hispanic and about 3% Native American. There are only 17% of their population is over the age of 65, but the median income is $62,000, with most of the state being insured, with only 12.5% being uninsured. North Dakota, it kind of lands in the middle. It has a population of about 760,000 residents, with an average population per square mile of 9.7 residents. Again, they are mostly white at 86% and Native American at about 6%. Residents in North Dakota, about 16% are age 65 or older, and the median income there is $63,000 a year, with only 8.4% of their residents being uninsured. So again, the mission and vision of Billings Clinic is to provide leading-edge cancer care and to be nationally recognized for the care that we provide. This service expansion is in alignment with both. This is a very growing service, and it has very promising results for the patients. The Yescarta that is approved is given for patients who failed two lines of treatment and generally don't have any other options. This has now been not only a hope, but it actually has been quite effective with outcomes. With that, it is definitely growing in use, and it would be unique for this region to have it. Also, with the FACT accreditation comes national recognition of the quality of our program. So the 3-year plan, infrastructure, as I said, thanks to the trial, is entirely in place. Our FACT inspection, we need to be FACT accredited before we can do immune effector cell treatment. It is also already in the works, and we're just waiting for word anticipated in November. We can, once we have that, start the FDA approval process to complete REMS training, which would be anticipated to be about 6 months into the year 2, to complete the REMS training so that we can be FDA approved for commercial products. With that would then be a review to ensure that our infrastructure and education of the staff and education of patients is current and covers whatever commercial products we would be providing, because they are unique. And it would be the hope that in the remaining 6 months of year 2, since we've already transferred 2 patients out in 6 months, that we would have at least 2 patients that we would be able to treat without having to send them out. Year 3, promote the program using billboards and site visits, which has been effective in the past, and with the goal of having 16 stem cell patients from the 8 we had this last year, and an increase to 5 immune effector cell patients. Our strengths, the infrastructure is already in place. To be able to do the review to ensure that it's current is already actually in my job description as the quality manager, and so it didn't involve any additional staff for that to happen. the comfort level of the trial, there is a 50% likelihood of cytokine release syndrome, which can be very life-threatening. Staff were very afraid of us starting CAR T-cell therapy. The clinical trial enabled them to increase their knowledge and to become comfortable with it. And there is a new transplant team, including myself, who are very supportive and pushing for the growth of this program and our recognition. Weaknesses: without accreditation, we cannot move forward. While we are waiting, the knowledge and the comfort level of the staff are decreasing, and those will have to be redone. The Yescarta cost $373,000 per treatment, with a reimbursement from CMS of about $400,000 if the patient remains outpatient. Our trial patients were kept outpatient. However, with such a high incidence of cytokine release syndrome, that is not necessarily likely to continue, and in which case we lose money. And as a small rural center, we are not equipped to absorb those kind of losses. Opportunities: this would provide us national and local recognition as a FACT accredited center, and one of the few in the nation who provide this service. We have no competition in this region, and bringing this to the region is a demonstration of our mission, vision, and values. Threats: without that FACT accreditation, we aren't getting anything done, and the poor reimbursement as to whether we could continue to absorb those losses. Market share analysis. External analysis: we are the only program in the region. St. Vincent's does not have interest. However, they have demonstrated some unethical behavior with our stem cell program. We did put a billboard outside of their facility touting our FACT accredited stem cell program, and even with the patient pointing out the window, they were telling the patient we do not have a program. We are trying to improve relations with them to improve that. However, it is affecting the number of billings patients we see. There is immunofactor cell accredited programs in Sioux Falls and Aurora, but those are outside of our region, and there are only 95 centers in the entire U.S., so this would be very unique for us to be able to bring this service to our region. We are well positioned with our current team and infrastructure. We have no additional costs. We fronted all the cost, money, time, efforts already with the trial, so those are all in place. There are no startup costs. This would truly be bringing the leading edge of cancer care to the patients of our region, which is aligns with our mission and vision, allowing us to keep patients close to home. There is also the potential that if we can continue to treat these patients outpatient, there would be $27,000 per patient revenue gain. Our payer mix, as you can see, is not likely to change. We're in line with other Commission on Cancer accredited facilities. However, the main difference to note is that 55% of our patients are Medicare. The ASTCT is, they are right now appealing to CMS to approve reimbursement outcomes, and so the results of that could have a significant impact on our program. So our promotion activities, like I said, we stay with what we know works, doing billboards and site visits. Our billboards, we have a marketing media research liaison who works at the cancer center. She does all of the layouts, presentations, billboard locations, and even the photography for our advertisements, including the billboards, and so there would be no additional cost there. Digital billboard, we had decided we would put up outside of St. Vincent's in June when we have an influx in tourism, and we would do that also with a regular billboard in December when, as a regional hub, we have people who come to us for tourism or for holiday shopping. The digital billboard costs $13,000 for 4 weeks, and the excuse me, and the regular billboard costs $793 for 4 weeks. The site visits, our clinical program director and our transplant coordinator would be the two who do this. In April and July, these dates were picked due to low census and good weather, and they'd use administration days, so their salaries on those days are already paid when they're not seeing patients. The only additional cost would be $40 for their rental car. These site visits and billboards, they increase awareness, and especially the site visits decrease fears. We've had providers worried we're stealing their patients. The promotion activities have relative low cost, and they also, with the billboards, increase the image and branding of the cancer center and Billings Clinic as a whole. So outcome measures, we cannot use profit margins due to we don't really have startup costs. There's a small patient volume, and there's no real cost to our promotion activities, so using that is not a good metric. The quality manager, I have been creating, I've been tracking patients by their location, but that doesn't show the effectiveness of our marketing. So I am creating a survey right now to determine how patients are referred to us and what their prior knowledge was before coming to the Billings Clinic. So our disruptors, again, is we need FACT accreditation, and the other problem is we have no succession planning. The clinical program director is holding 3 roles and has no backup to fill his spot. And I have at least 3 roles, and there is no one to fill my slot either if one of us were to leave. Product service line, the immune effector cell program would not, it would be done by the same staff as the cellular product, both falling under the cellular product therapy program, which is part of the cancer center, which is part of Billings Clinic as a whole. The processing facility would not be included on this though, because commercial products are manipulated by the commercial entity. Hospital staff who may care for these patients would be under the hospital service, but the insurance of their education and training would fall to me as the quality manager. So our projected revenue and losses assessments for the calendar year from 2020 to 2022, based on the assumption that we are keeping these patients outpatient, so we have the $27,000 per patient reimbursement. So what this slide shows is that without the expansion of cellular program to include immune effector cell, we are just continuing to send patients out. So all lost revenue is directly tied to us losing $27,000 per patient, with 2 patients transferring out in 2021 and 5 in 2022, which is our projected numbers. 2020, there's no cost going in or out with this year. Basically because we're still waiting on FACT accreditation. The 2021 projected revenue, this was with projecting that we would have a patient in June and another in September. We have no marketing cost for this year, so 2 patients would bring us to $54,000. However, if we ship them out, we now potentially lost the $54,000 we could have brought in. In 2022, we have that we potentially had 5 patients in January, March, June, August, and September. So that if we treated the patients, if we let them go. And additionally with this is just the loss of the patients. This one is the cost is deducted as well of us doing travel days in April and July, as well as the billboards in June and December. So, in conclusion, much of the cost, time, money, effort has already been done to bring this in service to the patients of our community. This is a very unique opportunity. We are already the only stem cell program. We could be the only immune effector cell program as well. CAR T cell use is only growing in use. And the opportunity for recognition to stand out as one of the few in the country is potential for this. Additionally, this truly does live up to the mission and vision of Billings Clinic, and most importantly, this is extremely promising for the outcomes of our cancer patients. There are my references. And I thank you for your time. Any questions?